I'd like to thank the organizers of the committee. I'd like to thank the Champalimaud Foundation for the opportunity to bring all of us together on this morning. I'm very thankful in particular that they've closed the blind over here so that, because I know I would be looking out the window if it were open rather than at the slide. So thank you all for your attention this morning. What I'd like to do is to speak about how AI can be harnessed to enhance cancer imaging, and many of my remarks will echo and maybe bring out a few other aspects of comments that have been made already today. I think there's an opportunity for us to look at AI as a way that we can bring increased power, increased ability to all the things that we do in radiology and address cancer imaging. Everything from beginning to understand which patients we should look at as those as highest risk, look at the screening technologies, detection of lesions, once we have a lesion in our sites to determine what its characteristics are. I'll talk a little bit about some of radiomics and some of the exciting opportunities that it brings. I think we also have a lot that we can use AI to improve treatment response tracking, just even some of the simple ways for those of us who do cancer imaging and struggle, as was mentioned, with doing RECIST measurements, just taking some of the tedium out of that, and then looking at ways that we can enhance reporting and improve the correlation of the imaging that we garner in radiology with that in other areas. So this was a work that was fairly recent in the journal Radiology, in fact, and as a way to improve, this was one that Evis just mentioned, a way to improve the measurement of risk in using AI and a deep learning model. And the idea being that not only can you take into account a typical model, which is the Trier-Cusick model, but that you can incorporate features from mammographic information on top of that and use deep learning to identify what are other aspects that are present in the images that can allow us to adjust the sense of our measurement of risk. And one of the things that was found in this, they used full field mammograms and traditional risk factors, but in looking at which patients that ended up with breast cancer were placed into the highest risk decile, in other words, the top 10% as measured by the risk index, the deep learning model identified 31% of those, and the more traditional model identified 18%. So really, there are some ways that we can use this to improve our risk profiling of our patients. I think when you look at broadly, we look at cancer screening, we have our intentional screening. We have screening programs in place for breast cancer, for colon cancer, for prostate, for certain populations. And we have new opportunities, I think, that are going to come to us by virtue of what AI can do, because it can do things for us that we could not really do before on a routine basis. And that is to look at lung lesions, to look at liver lesions, and to look at and to begin to do risk assessment on various lesions. And I think the question that's going to arise as we begin to do this is the cost effectiveness of those screening techniques and deciding which of those are going to be appropriate for us to carry forward based on the information that we have available to us. So just to get you to think about some of these, we know now that we can take measurements of various biomarkers that we find in our images on a routine basis. So for example, and these are from the non-cancer world, things looking at bone mineral density, looking at coronary artery calcifications to detect atherosclerotic disease, looking at emphysema, looking at cirrhosis in the liver. But all of those pieces of information don't detect cancer per se, but they can actually serve to help understand which patients might be at greater risk for tumors going forward. And it's pieces of information, again, that we really couldn't gather previously. Things, that one of the areas that's been of great interest, and at our institution, our head of genetics is a cardiologist and is very interested in looking at subcutaneous fat versus abdominal, visceral fat. and actually linking that to genetic and epigenetic factors that are related to gene expression factors that are related to coronary artery disease, among other things. But we're just beginning to understand how some of these factors may be related to predisposition for cancer, and how some of those are also related to our ability to combat cancer. So one of the areas, for example, is looking at muscle mass in the abdominal wall, looking at sarcopenia, looking at the lack of muscle mass, and the idea that we may be able to use that, one, as a predictive factor in looking at people, particularly if they've had imaging over time, to see if there's some evidence that suggests that reduction in muscle mass may be related to diseases such as pancreatic cancer, for example. And also one's ability to withstand treatment to cancer is based on, has relationship to muscle mass. So all of these things are actually, can be useful pieces of information that will feed into our ability to help treat our patients. In terms of detection, I think as was mentioned, one of the key aspects of this in all of these areas is the idea of doing segmentation and doing it correctly, being able to identify the findings within the images that are presented to us. And here you see a nice example of being able to detect a glioblastoma that identifies enhancing regions, the necrotic core, and areas of tumor that are not enhancing and surrounding edema, and being able to correctly identify these, because then information from those can be used to extract various factors that one can use in radiomic analyses of those tumors. And I highlight here just to talk a little bit about looking at mammographic breast density. You know, I think it's no surprise that all of us are looking at approaches to take the imaging information that we have and using AI as a diagnostic tool. And the idea that we have to test it and incorporate that with information that we have and be able to prove the utility of such systems is going to be critical to us. And I think one of the really interesting aspects of it is our ability to detect normals. And I thought it was particularly telling, as it was mentioned here, previously, that one of the keys for us, in fact, just in terms of workflow, if you can identify those exams in the course of your work that are normal, it takes a lot of burden off of it. It lets you relax a little bit, knowing that that you can get through that case perhaps a little more rapidly. And this was actually a nice study that published in European Radiology that looked at the ability to reduce mammographic screening by identifying normal exams with AI. And what they found is if you took this score of 5, for example, you could reduce it would exclude about half of the cases, but you did so with the risk of missing about 7% of the true positives. Whereas if you set your operating point differently and took the AI score of 2, you didn't reduce your workload so much. You maybe eliminated 17%, which is still pretty significant, and you only missed 1% of true positive cases. And interestingly, this pre-selection didn't change the area under the curve for radiologists at an operating threshold. The important point in all of these things too, and I think it's one of the challenges that we all face, is how much of an autopilot we want to have with AI. And I think we have to be very careful about that in going forward, because we really want these systems to act as a second independent interpretation with us as much as possible. And in order to do that going forward, we really have to make sure that we are remaining participants in this diagnostic process, and we're keeping our skills up. And I think that's going to be one of our great challenges going forward as we implement these technologies. One of the areas I think that's particularly exciting is this area of radiomics. And truthfully, we've been doing radiomics for a long time. And in fact, everything that we really do, I will tell you, the first time I heard someone talk about imaging phenotypes, I thought it was a bit of a ruse. Because it made it sound kind of sexy, so that we could fit all those cool kids were doing genomics, right, and we're just looking at X-ray pictures. And so the idea that, now we're doing that kind of stuff too. We're looking at phenotypes, right? But it is true. And maybe one of the big differences is, as you see in this image on the left, that what we were doing initially was we were saying, all of us, when we look at a lung nodule, for example, we look and say, well, how big is it? Is it spiculated? Well, these are characteristics that we're defining, and we're acting as the HI, the human intelligence, to try to determine these factors. What are the things that matter? And as best we can, we're teasing out the critical imaging factors. What AI and machine learning technologies have allowed us to do is, rather than us engineering those factors and then taking them off to the side and running some traditional machine learning approach, whether it support vector machines or other things, we can actually just give it all to the deep learning approach and say, you look at it, see what you're seeing in there, and identify features. And there's advantage to that, but it's also a bit of a challenge, because then the machine gives us an answer and we don't know where it got the answer from. We don't know what it was that it learned, and there's peril in that. So the idea of radiomics is we have hand-engineered features, shape, size, location, intensity, texture, wavelet features, and so forth. And then the deep learning models can just go in and find other features that we couldn't necessarily see, but that information can be used for survival prediction and to characterize the molecular qualities of those lesions. So here, for example, is some work that was published in AJR looking at glioblastomas, where they were able to identify IDH1 gene expression types just based on radiomic features alone, and being able to cluster tumors based on these imaging features. And that's really tremendously powerful. It lets you do kind of a virtual biopsy of the tumors, and that it lets us get at gene expression information. And this is some work that we just published in Radiology AI that looked at both texture features within and around the tumors in non-small cell lung cancer that allowed one to predict response to chemotherapy from the initial images, from the baseline CTs. And the information that was garnered from these texture features was associated with overall time to progression and overall survival of these patients. So that being able to actually take features that describe information within the lesion, here you see at the margins and then around it, actually provided really useful information that could be used to guide therapy, determine which therapies might be most effective for particular lesions. And then being able to cluster the information, cluster patients and diseases based on those factors. So just as seen here within this one, response to chemotherapy within the set of data, when it says training set here, within the overall set that was used with a held out test set, but then looking at it as applied to external data, still pretty good, but as typically the case, a little bit lower area under the curve for that. But significant prognostic value in terms of identifying time to progression and overall survival, which is nice. One of the areas I think in terms of treatment response that's going to be particularly helpful for us is just lesion tracking, just the ability to do measurements in a consistent way from one lesion to the next, and to be able to capture that information and then use that. And here, this was a study that, this one was published in Magnetic Resonance Imaging, that looks at using this to, again, take images and look at change over time to predict response to chemotherapy. And again, the idea that one can track these lesions, draw various boundaries about them, and then use the pre-treatment and early follow-up images in these patients to determine information to predict the response of tumor to particular treatments. This is really getting us towards where we want to go in precision medicine. And same thing here for looking at this for nasopharyngeal carcinoma, looking at prognostic value of deep learning PET-CT radiomics, identifying features that can guide therapy planning. This is really the kind of thing that we want to be able to do with these technologies. Same thing here for lung cancer treatment, being able to follow lesions over time and to improve the clinical outcome predictions. So I'm just going to touch a couple more things here. One related to radiology reporting. There are a couple of areas where just even in the very simple kind of low-level aspects of things we do, being able to take the measurements and the data points that come out of our imaging devices and from AI tools, and to be able to incorporate that directly into our radiology reports will be of great help to us. It reduces the possibility for error, knowing that the measurements that one obtain as you mark them up on your PACS just get automatically translated and moved over into the radiology report. And as well, that there are features that you might not even include and characterize in your report, but that would get cached into a database that would lie behind that information. One of the things that we've done at my institution is we have a coding scheme that we apply in abdominal imaging to all of our cancer cases. And it's really kind of like a little mini RECIST. We basically just describe if existing lesions have progressed, remained the same, or have improved, and then if new lesions are present. But one of the things that one is able to do is to actually take natural language processing techniques and apply those algorithms to characterize those responses. We're fortunate in our group because we already have sort of coded data that can serve as our ground truth for this. And so in this study, they actually just looked at, in a way, whether the words matched the way we had coded the information, and identified suitable NLP models that would allow us to track that kind of information. And the other area I just wanted to think of as we look forward at all of this, I think it's going to be really critical for us to look to integrate imaging information with pathology, with laboratory medicine, with genomics, and eventually with all the factors across the scale of how we understand healthcare. And I think tools that look to do that are going to be important. And so this was an article published in Radiographics, a tool called Correlate that uses data from PACS and the electronic health record to provide automated follow-up to radiologists, to allow us to take those cases where you may have reported a study or performed a biopsy, and now at least when there's a histological result, that it can track that and bring that information forward to you, or at the time that you're doing the next imaging study on that patient to make that available, to make that information available to you. And it uses the UMLS Metathesaurus. This is the Unified Medical Language System that comes from the National Institutes of Health. And the idea that you can use the system to know the context of information that you're dealing with. So it just provides you a way to extract information in relevant time and make that useful to you. So these are sort of all the dimensions, and just as was mentioned, the key things, and this is a very nice article on AI for cancer imaging challenges and applications. Looking at detection for lung, for glioblastoma, prostate cancer, breast cancer, and so forth, for characterizing the lesions as we detect them, as was mentioned, involving segmentation, diagnosis, staging, genomics, and then monitoring these lesions, looking for change over time is one of the keys going forward with this. So what's needed to bring AI into cancer imaging? I think we need large, well-annotated data sets. They don't have to be on the order of millions of images. I think we're improving a combination of transfer learning techniques in AI, so-called, and the ability to do some other ways of doing model training. I think on the order of tens of thousands, but we need good data sets that we can use to train these. There's a lot of interest and work already underway to develop standards to allow us to exchange data, not only for the models that we build in AI, but also to integrate these tools more effectively into the clinical workflow. It's critically important we have clinically important use cases. There are brilliant people out in computer science who are working on these techniques, but it's really important that they connect with people, I suspect like most of you who are here as clinical radiologists, to understand what are the really important problems, what are the challenges of doing this. You know, it's taken us dozens of years to understand cancer is not a monolithic thing. Breast cancer is not monolithic. Even an individual breast cancer metastasis is not a single thing. It's really almost a community of different clones of tumor, and we have to understand its behaviors, and we have to understand how we can approach treatment to these lesions. I commend the Champalimaud Foundation and all of you for coming out here. I think education about AI is the single most important thing. I mean, a lot of people have been driven to this, I think, by fear that somehow AI is going to replace all of us. I don't believe that. I think AI is going to empower us. I think it's going to be something that we can harness to use more effectively. We need policies and ethical guidelines. We need high-quality research. To that end, I will put in a shameless plug for this new journal that has been created by the RSNA called Radiology Artificial Intelligence. I'm very pleased to say that a number of as they say, the most important thing you can do when you're in charge of something is bring on people who are smarter than you, and the deputy editors and the associate editors we have on our editorial board clearly do that. We have some wonderful people. So just, again, I think for AI and cancer imaging, the goal is to automate the rote and boring stuff, to mine imaging features to help us advance precision medicine, to integrate imaging at all scales, to lead big data research in this area, to capture information that we need to drive comparative effectiveness research, and most importantly, to make our patients healthier and better. Thank you very much.